Welcome back to Revenue RX, the podcast at the intersection of pharmacy and finance. In today's episode, we're talking about drug pricing, starting with what you actually pay and then moving into how you get paid. Before we get started, a quick disclaimer. This podcast is for informational and educational purposes only. The views shared are my own and do not represent any organization I am affiliated with. This is not legal, financial, or reimbursement advice, and you should consult your internal experts before making any decisions. If you turn on the news, the narrative is simple. Drug pricing is rising, manufacturers are to blame, and the system is broken. In 2024, overall pharmaceutical expenditure in the U.S. did grow by 10.2% compared to 2023. And there are therapies that have come to market that are $4 million per dose. But if you actually work in pharmacy, finance, or revenue cycle, you know that the reality is far more complex. Drug pricing is not actually one number. It is a combination of alphabet soup. Let's start with what I think is the easiest pricing to understand, which is purchase price. Wholesale acquisition cost, or WAC, is the manufacturer's list price. Think of it as a starting point, or an item at the grocery store that is full price. It does not include any discounts, rebates, or any additional cost reductions. The goal is typically to minimize WAC spend because no one wants to pay full price. Next, we have GPO pricing. GPO stands for Group Purchasing Organization. Two big ones you might have heard of are Vizient and Premier. Group purchasing organizations negotiate pricing on behalf of health systems. They use aggregated numbers to increase buying power. This is where most hospitals are buying drugs that are non-340B in a non-340B setting. Your GPO price is typically WAC minus a percentage. Depending on your contract tier, volume discounts, or if you have purchasing commitments, that percentage is higher or lower. GPO discounts can also be seen in the form of rebates. Some drugs are competitively contracted and offer strong discounts when there is a market share requirement, while others, like single source or sole source products, usually are priced close to WAC. If you are a 340B covered entity, this is one of the most impactful purchasing levers you have. 340B pricing is significantly reduced compared to WAC and GPO. Congress created the 340B drug pricing program in 1992 in the Veterans Health Care Act to enable certain healthcare safety net providers to purchase drugs at a lower cost. The 340B program enables covered entities to stretch scarce federal resources as far as possible. 340B is only for covered outpatient drugs and comes with strict compliance requirements, eligibility rules, and increasing scrutiny from both regulators and manufacturers. Not every drug location or patient qualifies for 340B. At this point, we have 3 different ways you might purchase the same drug. WAC as the baseline, GPO as your negotiated price typically used in the inpatient setting, and 340B if you're a covered entity and it is used in qualifying outpatient settings. Now let's shift to the other side of the equation, reimbursement. Because what you get paid does not always align with what you paid. One of the most important benchmarks here is average sales price, or ASP. ASP is based on actual sales data submitted by manufacturers. It includes discounts and rebates, so it is much closer to the true market price. Medicare Part B typically reimburses drugs at ASP plus 6%. So this is a really good reference point. If your acquisition cost is below ASP, you have margin. If it's above, you're at risk for losing margin and paying more than what you will be reimbursed. Then we have average wholesale price, or AWP. AWP is often used in commercial contracts, and a few years back, this was a common price point that was used as a basis for charges. AWP is not a true market price. It is inflated and at times feels like a made-up number. There is not a clear way of how AWP is calculated, and it is published by a third party such as Medispan. There's also actual acquisition cost, AAC, which is also used by Medicaid to set prices. It's also used in the cell and gene therapy space for products that require health systems to submit an invoice to be paid for the acquisition cost of the drug. If your teams are not looking at both sides of the equation, you are missing the full picture. In future episodes, we'll go deeper into how these prices show up operationally, including charge capture, coding, and reimbursement validation. Healing patients is the mission. Protecting the margin is the strategy. This is Revenue RX.